Okay, so this lesson is on prenatal development. Please review your slides for lecture 1 and 2. Well, now that we've conceptualized the history of developmental psychology, the domains of developmental psychology, the research methods, now we get to talk about some of the research. So lecture 3 is all about prenatal development and birth. So, mazel tov. Okay. So, before I get into this, I think it's important to talk about genetics as a predisposition. So, I asked about genes and chromosomes already, but let's try and highlight this. A genotype is the genetic material that makes you who you are. Now, genotypes typically influence phenotype. Phenotypes are the outward expression of the gene. So I always like to say genotype is what happens underneath the surface. Phenotype is the overexpression. So if a person, let's say, has blonde hair or blue eyes, well, that's a recessive gene that makes them outwardly express blonde hair, blue eyes. Okay, so in terms of genetic code, everything goes back to a cell. A cell is a basic unit of life. And in a cell, there is the nucleus, and this is the control center of the cell. As part of the nucleus, you'll see we have your genes and your chromosomes. So chromosomes are rod-like structures of genetic material, and genes are made up on the chromosome. Now, if you look at the left side as I move my cursor, this is a chromosomal blueprint, right? So we have 23 pairs of chromosomes. Now, if you look at the number here, it says 22, right? So those 22, as we will see, are called autosomes. And then we have XY here, that is your sex chromosome, and XY is male. So 23 pairs of chromosome, or 46 in total, and then we have genes along the chromosome. So if you were to look at genetic expression, everything comes down to DNA, or deoxyribonucleic acid, and there are 4 base pairs that you could know. There's adenine and thymine, guanine, and cytosine. My mnemonic to remember which base pairs link together is you can mess with your metabolism at GNC. That is to say, adenine links or pairs with thymine, guanine links with cytosine. Now, you'll also notice that there's this beautiful double helix, right? That's what the DNA is. But how do we duplicate genes? This process is called mitosis, and you'll see that it splits into 2, and then it makes its own base pairs. And then it goes through this process over and over and over, and that is the duplication of DNA, and we have our genes. So there's another process, which is the duplication of gametes. And what are gametes? Gametes are sex cells. So male gametes are your sperm cells, and female gametes come from the ovum. Each one has the 23 chromosomes, right? So 23 chromosomes are in the sperm, 23 chromosomes are in the ovum. They fuse together, and then they turn into a zygote, right? So you have these various gametes, sperm cells and ovum cells. They fertilize and they turn into a zygote. All right? So when we talk about boy versus girl, what is a child? Biological sex is determined by the 23rd chromosome. In general, as I showed you on that blueprint, there are 22 autosomes. These are matching pairs. And then the 23rd pair is your sex chromosome. So you have an X or a Y. The X is associated with being female. The Y is associated with being male. Now, moms can only give an X chromosome, obviously. dads can give an X or a Y. So this is probably why you've heard that the father or the male is responsible for determining the sex of the child. Okay, so twins, are they identical or are they fraternal? Well, that depends whether or not the ovum released or the ovary released one egg or two eggs. If the ovary released one egg, mono, one, zygotic. So what happens is one egg and one sperm fuse together, but how do you get twins this way? So this fertilized egg splits into two. And that's why they're called identical, because both genetic pairs are absolutely identical, because it's the same sperm cell, same ovum that fused together and then split into two. So they share all genetic material. Sometimes when a person ovulates, they release more than one egg. And this is what we call dizygotic, so, or fraternal twins. This is where two ova are released and fertilized. Now they're basically like two siblings sharing a womb. Now, when does this happen? How does this happen? Well, typically you release one, but as you age, or if you use fertility drugs, or if you use IVF, you're more likely to have fraternal twins. Okay, so the next thing to talk about is genes and genetic inheritance. So we talk about alleles. So what is an allele? Allele is a version of a trait. And you could have two alleles, right? Now, if the two alleles are identical, we refer to it as homozygous, right? If they're not, if they're not the same, we refer to them as heterozygous. So the alleles are different. Now, why is this important? Because dominant traits come from heterozygous alleles. Recessive traits come from homozygous alleles. Okay, so the dominant and recessive relationship, it's important to understand what genes are dominant, what genes are recessive, and understand some of the recessive gene disorders. And I want to talk to you about this, that genetic testing is actually very, very powerful and it's important. Most expectant mothers are given the opportunity to do a blood panel, and they're looking for general issues. But if you come from Eastern European Jewry, they offer you to do a whole host of other genetic testing. So for Tay-Sachs and Crohn's disease and so forth. If you come from an African American community, they may offer you the opportunity to test for sickle cell anemia. If you come from a Mediterranean community, they might offer you to do Mediterranean disease. So what is interesting is that these are genes that are passed on in a recessive type. Now, one of the things that we see is that for recessive gene disorders to be expressed, both of the genes must match. You must have homozygous alleles, right? So it's interesting, people are so afraid, in certain communities there's a discussion, oh, you don't want to intermarry, you don't want to have mixed ethnic relationships. I actually think that genetic diversity is a beautiful thing, and it serves a protective effect. So genotype and phenotype are related. I know some people may come from very conservative families who want you to marry within your own group, but marrying or dating or having kids outside of your own group may actually be a good thing. And we see that particularly with the genetic relationship. So we talked about dominant and recessive, but there are other kinds of genes. There's something called a modifier gene. And basically a modifier gene is when one gene either enhances or dilutes the effect of another. So let's take the case of phenylketonuria. So PKU, or phenylketonuria, is a disorder where a child cannot break down phenylalanine. And the problem of not being able to break down phenylalanine is the more you have, the more it becomes a neurotoxin, and it could result in brain damage or potentially even death. So, but you're probably thinking, well, that's phenylalanine. It's a recessive gene disorder. Why are you talking about it? Well, we see that the gene that is associated with phenylalanine is also associated with hair color and eye color. So let's look at this recessive gene. We have mom, we have dad. They have a capital N for a normal gene, a lowercase p for a gene for phenylketonuria. Now you'll notice, because it's a recessive gene disorder, neither of them actually have PKU, but they can carry it and express it to their kids. So what are the possibilities? If both parents express the normal allele to their child, then the child will be considered normal and cannot pass on PKU to their kids. If either mom or dad pass on the allele for PKU, their children are in the same boat. They're carriers, right? So they don't have PKU, but they can give it to their children. Now, what happens if both mom and dad give the lowercase p, right? Then the child has PKU. Now, they have to have a special diet. They have to avoid phenylalanine, which is heavily found in diet soda and gum and so forth. And then the metabolism or the gene kind of starts to kick on later. But aside from having PKU, you'll notice both mom and dad have brown hair, brown eyes, but this kid with PKU is a blonde hair, blue eye child. So that demonstrates the concept of a modifier gene. I also want to talk to you about, like, some of you before this lecture may look at a kid and look at the phenotype, the outward expression, be like, both parents have this hair color or this eye color, and the kid comes out with a different hair eye color than the parents. And then you're like, that's suspect. And you're like, was it the mailman? Was it UPS we deliver? No, just kidding. In reality, it could just be that both parents were carriers for blonde hair, blue eyes, and because the brown hair, brown eye combination is a dominant gene, it wasn't manifest in their child. So, or it wasn't manifest with them, but their child has it. Another kind of genetic inheritance is called codominance, where basically both alleles have equal value or influencing heritage. Other things we want to talk about genetics is X-linked inheritance. This refers to the harmful allele that's carried on the X chromosome. Now that's important because males only have one X chromosome. So if there's some mutation or some problem with the one X, they're going to be more affected by it, whereas females have a second X chromosome, which could counteract that. All right, so how do we look at this? We can study it through genetic imprinting, so the alleles are marked and activated to see how they play a role. Now, other things we need to know is concept of mutation. So just because you have a certain genetic makeup, you can actually have a mutation that you pass on to your children. So genetics usually are passed on to you. If you have a mutation, you then can pass it on to your children. And usually that happens due to some kind of environmental factor. I think I talked to you about Kellerman's research in the Holocaust with PTSD. How about psychology, disorders or whatever? One of the interesting things about genes and psychology or personality, intelligence, and so forth is there's something called polygenetic inheritance. It's never one gene. Multiple genes come together to make you who you are, to express the personality or intelligence or so forth. Okay, so let's talk about genetic disorders. First, we'll talk on a chromosomal level, right? So on a chromosomal level, we have something called Down syndrome. Now, Down syndrome is also referred to as trisomy 21. And if you look at the word trisomy, it starts with tri, T-R-I, which is a prefix that usually means 3. So a tricycle is a three-wheeler. A triangle is a three-sided shape. Trisomy or trisomy is a chromosomal pairing that has 3 instead of 2. So with Down syndrome, there's an extra chromosome. Now, you can have a trisomy on any of the 23 pairs. And in fact, if we look at the sex-related chromosome, you can have an XXY pairing, which is called Klinefelter's. And this usually results in sterilization and intellectual disability. Other trisomies on a sex chromosome is XYY. That's also a male. And we once thought that XYY was associated with aggression, and it proved out to be incorrect. These individuals do have greater athleticism and so forth, but cognitively there are some limitations. And then we have XXX, which is a trisomy for females, and the same thing as XYY. What's interesting is that this does result in higher growth. It does result in greater athleticism and so forth. But there are some cognitive delays, but they are not intellectually disabled. So some trisomies are going to result with an intellectual disability, some are not. All right, so just like you can have a trisomy, you could be missing a chromosome. So Turner syndrome is noted as X and blank, left that way. X underline, which alludes to the fact that the second chromosome is not there, or XO, being that the second chromosome is absent. So these are the notation for that gene. And instead of having 2 chromosomes for XX, these females have 1. So what does this do? Well, they have all the primary sex characteristics, so they can reproduce, although their window of time is more truncated, but they don't have the secondary sex characteristics. And I don't think I defined primary and secondary sex characteristics, so I'll do that now. Primary sex characteristics are all the essential components of the reproductive system. So the ovaries down for females, and for males, testes down. So this is going to allow you to reproduce. Secondary sex characteristics are usually the signs you see when a person hits puberty. So this might be the enlargement of the breasts, widening of the hips, and so forth. So these young ladies would look prepubescent, if that makes sense, who have Turner. And I think there was a Law and Order episode on that, but I'll leave it alone. All right, so we have examples, as you've seen: Down syndrome, Turner syndrome, trisomy X, Klinefelter's, and XYY, as I talked to you about. Now, if you are concerned about the genetic profile that you have, you can get genetic counseling. Now, most people don't think of genetic counseling unless they're having a problem getting pregnant, or as they get older, or there's some real concerns about heritage-related disorders. So, but genetic counseling is useful. And in fact, I'll share with you, before I married my ex-wife, we did a blood panel to test whether or not our children were at risk for a lot of these disorders that are associated with Eastern European descent. We were fortunate enough to find that there was no problem, but genetic counseling can be very useful. Now, you also have something called a pedigree study, where you look at the family tree and see which members have certain disorders, and that can help you calculate the likelihood of having an abnormal child. Okay, so genetic counseling is there if you're into that. I strongly recommend, I think genetic testing is pretty cheap today. I actually have always wanted to do 23andMe, largely for the cultural aspects of genetics, but it's curious. I I think everyone should do it, but that's just me. All right, so now let's talk about prenatal development. So how can we test problems prenatally? Well, there are some really routine or safe procedures that everyone does, and then there's more risky procedures. So let's go. The ultrasound, everyone knows, it's in every Hollywood movie where they put the jelly on the belly and they move it around, and then they want to see if the child has a heartbeat, whether it's moving, etc. This is routine, it's non-invasive, very safe for the child. There's another way to do it, blood sampling. Again, here you're drawing blood from the mom and you're trying to test the blood to see if there are any kind of disorders. And there are a lot of things you could detect, like an anencephaly, spina bifida, trisomy 21. Blood sampling is important. Your OBGYN will ask you, do you want that? And in some religious communities, they don't do it, so they opt out. But it's available to you. So these are pretty routine. Now let's talk about the more risky procedures. So the two are amniocentesis and chorionic villus sampling. So amniocentesis. Now this, if you look at the picture, I'm moving my cursor here, look at the first one. So here you have the vaginal canal, here you have the chorion, here's the baby, and in this red here, this is fluid. Right, so this is, I don't know, it's the, shoot, I'm drawing a blank. It's the fluid that protects the baby, right? So you draw that fluid and you could test the fluid, right, in the amnion for all kinds of disorders. But what makes it more risky than the other two? If you see there's a needle that you have to stick into the womb. Well, anytime you stick a needle into the womb, that's risky, right? Because you can puncture or the child or whatnot. So that's that. And then the second one is chorionic villus sampling. Now, as I said, the pink here is the chorion, right? So the chorion, it's called villus because they look like fingers. You take cells from here and you test these cells. But notice you have a needle here, you have the ultrasound, and then you have this clamp and another needle here. So it's a little bit more complicated. Okay, so these are ways to test for disorders. Now let's go through the three phases. The three phases of prenatal development are conception, prenatal development, that's conception all the way up to birth, and then birth. And I'm going to go through each of these stages, and I won't, maybe I'll tell a joke or two. Who knows? All right. So if you look at this, this is a standard ovulation cycle. So if you were to ask, well, what is the average length of time from the beginning of one period to the next? It's 28 days. So the typical ovulation cycle is in the middle. So here's the last period, right? And then day 14 and day 15 are when ovulation takes place. So let's go through the stages. Now, here's the deal. Some people have a longer distance between one period and the next. Some people have a shorter distance between one period and the next. So put my little asterisk there. If your menstrual cycle is shorter than 28 days, it's not my fault. And also that would affect your ovulation day. So put that there. So if you look at the sequence, though, you have the menstrual phase, which is 4 to 5 days of flow. Some people, as you get older, you're going to see 4 to 5 might become 6 to 7. Then you have the follicular stage, which basically is the walls of the uterus thicken and prepare for ovulation. Now this thickening, it's important because if you fertilize the egg, that egg is going to have to latch to that thick uterine wall. So that's good. Now, what promotes ovulation? There's a hormone called estrogen. Now, then day 14, day 15, you ovulate, right? So you ovulate, and there it is. It can last between 1 and 2 days. And then if you don't fertilize this ovum, then you start preparing for your next menses to flush out that egg and prepare for the next one. And that's called the luteal stage, where you're preparing yourself for the next ovulation cycle, and that's driven by progesterone. Now, this is an important public service announcement. You might say, okay, because if a person's sexually active, they're like, oh, that's great. So you mean to tell me that as long as I avoid my romantic partner on day 14 and day 15, I'm good? So one of the things that we say, again, we don't know if you're ovulating before day 14. That's one issue, or after day 14. But let's even assume that you ovulated day 14, day 15. The life of a sperm is anywhere between 3 to 6 days, right? So if you have Michael Phelps swimming upstream, you could have just got done your period, and then all of a sudden that sperm finds its way to the ovum, and then you have an unplanned pregnancy. So if you are truly intending not to get pregnant and you're trying to test your ovulation by counting days, that's risky business. I would recommend against that. And I always say, if you're not planning against, you're planning for a pregnancy. So the only way to plan against a pregnancy is contraception. All right. So congratulations. Let's assume that you wanted conception to take place. This is what conception looks like under the microscope. So you'll see that that sperm is burrowing in to the ovum. And eventually what it's going to do is it's going to fuse together. And then once one sperm penetrates the egg, it's like Fort Knox. The gates close, nothing gets in, nothing gets out. And then this fertilized egg starts to create the child, right? Okay, so the cell burrows in, fuses together, and then you start to have the cell division, split, split, split. Eventually it becomes a blastocyst. So congratulations, we now have conception. So now moving from conception, here are the developmental stages with prenatal development, right? So the first stage is called the zygotic or germinal stage. That's from conception to about 2 weeks. And you have this, probably the most dangerous mission of this child or developing child happens in the zygotic stage. And that is to latch itself onto the uterine wall. Remember what I said? That as you're preparing for ovulation, the uterine wall gets thicker because we want this child to latch on, right? Because if it doesn't latch, then you have no child, right? Okay, so, all right, so we have this journey towards implantation where this blastoplast burrows into the uterine wall, and we start to have the process of the developing child. Also, I thought another microscopic picture would be cool because here's the what looks like an egg that's latched on to the uterine wall. And here's the amnion, right, which is the membrane that protects it, and then we have the amniotic fluid. That was what I was thinking. So amniocentesis was the amniotic fluid that you needed to draw. Now, here's the deal. Less than half of fertilized eggs actually implant on the uterine wall. So most people don't even know they were pregnant because it's flushed out in the form of a period, and they don't even know. But let's assume that it starts to take hold, right? So the other half, that latch onto the uterine wall, we start to see the development here, right? So we start to see the placenta and umbilical cord. We start to see the chorion from the chorionic villus sampling, and we start to see the amniotic sac and fluid, etc. Basically, we're starting to prepare for the development of a child. So let's go through the various components and their important roles. So the chorion, this thick layer here, it's basically a buffer. It's almost like, have you ever seen in gyms, they have like mats against the wall, so if you run into the wall, it doesn't hurt. So this is like a mat or a buffer to protect the child. We see the placenta. The placenta and the umbilical cord play a major role, right? Because this is going to give the oxygen and remove waste, and the umbilical cord is what's giving the nutrients and getting rid of the waste. And problems here result in toxins poisoning the child. So we have the zygotic stage, we have the embryonic stage. So the embryonic stage is from implantation, so roughly 2 weeks, all the way through up to and including 8 weeks. So that process, let's talk about it. We have the last half of the first month, we start to see that these cells are now developing the structure of an organism. So we have the ectoderm, ecto being outer, derm being skin layer. So this is going to become your skin and your nervous system. Then we have mesoderm, meso being middle layer. This can be your muscles and organs and so forth. And then we have the endoderm, endo being innermost layer. This is going to be your digestive, urinary tract, lungs, and glands. So we have skin, nervous system, muscles, glands, organs, all developing. And then we have the brain and spinal cord developing as the neural tube, right? So that's from week 2 to week 4. Now the second month, week 4 all the way to week 8, we start to see a heart starts to beat, the liver starts functioning, the internal organs become distinct under ultrasound and so forth. Now I guess at this point of the lecture I should ask the question, when I'll ask the question about abortion. When, from a life point of view, when does life begin, right, in terms of abortion? So, well, the more religious people will say it begins from conception. What are you talking about? A cell is the smallest unit of life, and you have these two cells, a sperm cell and an ovum, fusing together. So life begins at conception, and therefore, from a religious point of view, abortions are forbidden, even from conception forward. Now, that logic is kind of flawed, if you ask me, because if you're concerned about destroying cells or murdering, we could never scratch our face, because every time you scratch your face, you're peeling skin, and that's a whole bunch of skin cells, right? So if that was the worry that, oh, a cell is the smallest unit of life and killing the smallest unit of life is murder, and we could never scratch our face or whatever. So let's remove religion out of the equation and talk about what people start to argue. Is this a living entity, right? So the question is, let's look at 2 months when you start to see the heartbeat, the liver's functioning and so forth. Is that a living entity? And many people say yes, right? And that's why people have a hard time, even if you take religion out of the equation, with abortion, because very early all of the organs are developed and it's a mini child. Now, some people will argue that yes, but if you delivered this child at this point, it's a non-viable organism. And because it's non-viable, it's not life independent, and therefore it's okay until we get to what's called the age of viability. And you'll notice that abortion law, the age of viability is about 6 months, right? 22 to 26 weeks. And therefore, most states, if not all states, ban abortion after 6 months because the child could live, and the exception is if there's bodily harm to the mom. Okay, so that's the whole discussion of abortion, and there are 3 opinions, and it all depends on when we start the clock on life, from a cell, from a heartbeat, or from a viable fetus. Okay, so let's talk about the fetal stage. So this is from week 9 all the way till birth. Now you'll notice that I don't really say the end point because you have premature birth, right? So from week 9 forward, it's considered the fetal stage. So what's happening in the 3rd trimester? So all the organs, muscles, and nervous system become integrated and connected. You start to see the genital. They become formed, so you could determine the sex of the child. You could hear the heart with a simple stethoscope by now, and by the end of the 3rd month, you have your 1st trimester done. Check. Okay, your 2nd and 3rd trimesters, what's happening in your 2nd trimester, you start to have vernix and lanugo. So let me explain to you how this works. We said that the fetus is sitting in amniotic fluid, right? So what happens when you sit in a bath too long? Well, your skin starts to prune, and if you sit in there even longer, the skin starts to crack and bleed. Well, this child is going to sit in fluid for nearly 10 months, right? So we cannot have this child bleeding without any protection. So what's brilliant, and I'm going to go out of order to explain how this works. You have lanugo. Now the term lanugo you may have heard with eating disorders, right? It's that silky blonde hair that you get. So you have hairs, these fine hairs on the child. And then you have vernix, which is sort of like that white cottage cheese looking appearance. And what that does is it sticks to the hair, the lanugo, and it serves like lotion for the child so the child doesn't have chapped skin. It's actually pretty brilliant. And then we have the 3rd trimester. As I said, the age of viability. This is when the child, if without the mother, if the child were delivered, the child could breathe and live on his or her own, and that's between 22 to 26 weeks. And then obviously from that point forward, the brain continues to develop. Now, I talked to you about in last class the neural tube. So here's the spinal cord and here's the brain. And this is 25 days, right? Then by 50 days, we start to see almost what looks like the structure of a brain. It's just not laid in on itself, right? So we have the hindbrain, the midbrain, and the forebrain. And then by 100 days, it's starting to settle. 20 weeks, it's really in place. But at a certain point, the cells are developing so rapidly that we're running out of space. So you'll start to notice that these lines start to appear, right? And these are called convolutions. And this is the brain folding in on itself to occupy space more efficiently. Now, for a demo, give me a second. All right, let's imagine this is your brain, okay? Let's imagine this is your skull. How do we get the brain in the skull, right? This is the brain tissue. If it stays as it is, it can't fit in, right? So those wrinkles are really brain folds. So the brain folds on itself, it folds, it folds, it folds, it folds, it folds. And now the same brain fits into the skull very nicely. So when we look at this picture here with all these wrinkles, these convolutions are basically maximizing the space in your skull for the relative growth of the brain. Now, one thing I need to talk to you about is something called teratogens. The word teratogen comes from the Greek root teros, which means a monster or malformation. So a teratogen is basically a mutation that can occur as a function of some kind of harmful agent that passes the blood-brain barrier and affects the development of the child. Now, teratogenic effects depend on many things. So dose, the higher the dose, the more negative the effects are. Heredity, so some people have more genetic buffer than other negative influences. So there could be a synergistic effect between stress and drug use, let's say, and then age. The older you are, the more likely you're going to have a teratogenic effect. So, what is the impact of teratogens? Well, it depends on the age of exposure. So, as I said, there are 3 prenatal stages. There's a zygotic, embryonic, and fetal stage. The zygotic stage, first 2 weeks, doesn't really have much of an impact. You know why? Because what happens is the agent is so strong, usually flushes the fertilized egg out. You get your period, you never have a child, right? Now, the embryonic stage, or the embryo, weeks 2 to 8 are prime time. These are the worst time to expose your child to a teratogen. Why? Because everything is developing between weeks 2 and 8, and it's your primary development. And I'll show you what I mean in a minute. And then the fetal stage, most things are finished their primary development, so teratogenic effects are less. However, you could have brain damage, eye mutations, and genital impact. And sometimes you don't even know the impact of teratogens till much later. For example, high cocaine use might result in cognitive delays. So let's look at this. So here we have, in purple, the zygotic stage, weeks 1 through 2, right? There's fertilization, then cell division, split. Eventually it latches onto the uterine wall. Exposure to a teratogen will flush the system usually, and that results in prenatal death. So weeks 2 through 8, right? So the end of week 2 all the way through week 8, you start to see the central nervous system, the heart, eye, everything is developing, right? So the list is here, but everything is developing between weeks 2 to 8. And exposure could result in serious or major abnormalities. Now, you'll also see in the graph, that wasn't supposed to happen. There's the blue, and then there's the green. The blue is reflective of primary development or essential development. So if you look at the blue, almost everything finishes developing before, in its primary sense, before the end of week 8. Only the central nervous system, which is the brain, your ears to some degree, your palate to some degree, and your genitals, in their primary sense, continue on. Everything else is pretty much solid, and that's why we said during the fetal stage the impact of teratogens is a little less. It doesn't mean that you should expose yourself to teratogens, but it means that prime time is weeks 2 to 8. And I'm going to continue, and then I have a very valuable life lesson there too. So let's talk about some of the teratogens. One is called thalidomide. So thalidomide was a drug that they gave to combat morning sickness. Some women become exceedingly nauseous when they're pregnant. And this was a drug that helped with morning sickness. One problem: it also resulted in damage to the heart, kidneys, ears, genitals, etc. So they pulled it off the market. But it's come back on the market. And you probably are asking yourself, but why? Well, there are other conditions where people have serious nausea and they're not pregnant, right? So if a person has cancer, or a person that has AIDS, or any number of things, they might get nausea, and they may not be carrying a child, so you don't have to worry about the malformations. Then we have DES. This was to prevent miscarriage, but it resulted in vaginal cancer, infertility, and mutations in the uterus. So they pulled that off. It's gone. And then we have something called Accutane. Every teenager is worried about their appearance, right? Or most teenagers, I should say. And they're like, oh, to have this, that, oh, look at this pimple. So they put on Accutane, and it helps with acne. The problem is, what if you're with child? What if you're expectant? Well, this could result in eye, ear, skull, brain, heart, or immune system damage. Okay, other things. So aspirin. Something simple as for pain might be result in low birth weight, lower intelligence, infant death, etc. Caffeine. High doses of caffeine is problematic because low birth weight, the child comes through withdrawal, and there are some heart problems there too that's not listed. Antidepressants. Sometimes if a person is taking antidepressant medication, the doctor will ask, well, are you pregnant? Why? Because certain medications could result in breathing problems or withdrawal problems and so forth. Now, you'll notice, let's go through some of the illegal drugs, and marijuana is complicated because some states it's legal, but in general, on a federal level, it's illegal. So opiates, we're talking about heroin, we're talking about painkillers, and so forth. This is problematic because you tend to have premature children. Now, a preemie, or being premature, is born before 38 weeks. Low birth weight, physical mutations or the effects, breathing difficulty, and then you have to withdraw the child. So many times they go to a neonatal intensive care unit, and then they're sort of like going through withdrawal. And then you have sometimes they wind up dying as a function of it. What are some of the mannerisms of this child? They have a hard time sleeping, they're feverish, they are inattentive, they tend to cry more. So that's opiates. Now, what about stimulants like cocaine and amphetamines? Well, they have all of the other problems, but they also have eye, bone, genital, urinary tract, heart abnormalities, and so forth. Marijuana, you have a lot of cognitive problems. Ooh, this is not good. I'm getting a low battery sign. I'm going to stop the recording. Okay, so we're back. I had to move the laptop a little bit, put in a plug, and here we go. So we talked about illegal drugs. Now tobacco. Tobacco is a serious problem. It's associated with low birth weight, miscarriage, premature birth, asthma, cancer in the future. We also see it's associated with sudden infant death syndrome. And then if you look over here, you'll see that it's the more you smoke as a mother, the more school failure and learning problems your child has. So it's associated with cognitive problems too. And then one of the things that you need to be mindful is the concept of secondhand smoke. So you should avoid smoke-filled environments. Now, in New York City, it's nice. All the restaurants are smoke-free now, and that's for this purpose. But it used to be that you would have to ask for a non-smoking section of a restaurant. Now, alcohol. Before I go into alcohol, I may have asked, I may not have asked, but I'm going to throw out the question for you to think of, then I'm going to give you the answer. What is a safe amount of alcohol? So you're probably thinking, well, if coffee you could have up to 3 cups, maybe a glass of wine is fine, but that's not true. According to the Center for Disease Control, there is no safe amount of alcohol. When should you stop, right? Well, you should stop anytime you're having unprotected sex, because usually the first time you notice that you're even pregnant is when you miss your period, and you might get your period your first trimester. And as you saw earlier, weeks 2 to 8 are serious. right, for development. So you may have already exposed your child to all kinds of harmful agents, which is not good. Now, other teratogens, excessive exercise is dangerous. Moderate exercise is fine, though. Ask your OBGYN. Protein, you need sufficient protein. If you don't have enough protein in your diet, that could result in intellectual disability. All forms of radiation could be problematic. In fact, that's probably why your dentist asks you, hey, are you pregnant? And if so, your dentist will say, I'll see you in 10 months. And then all forms of viruses like HIV or AIDS, you run the risk of passing that on to your child. Now, childbirth. Childbirth can be also divided into 3 parts. So let's go through it. Dilation and effacement of the cervix. Basically, remember that thick uterine wall? It needs to thin to nothingness, right? And that's effacement. Dilation is the opening of the aperture. You need to open the vaginal canal up to 10 centimeters, which is roughly the circumference of one's hand. This usually doesn't occur quickly, particularly with first child. You have contractions, and that serves the purpose of dilation and effacement. It could take you 12, 14 hours. Subsequent births are a little bit quicker. Delivery of the child, this is about an hour for first child. It's pushing. This is the active pushing process. And then you deliver the placenta, or the afterbirth, and that's pretty quick. So if you do the math, this, according to the slide, should take you about 15 hours for your first child. These are rough estimates. Our first child, my ex-wife and I, it was almost a full day, and they were going to induce her at that point or do a C-section. So there are individual differences. Now, the stress, if you look at cortisol level or stress hormones, catecholamines, the highest stress is the child. Right? This child, during labor and delivery, is undergoing a lot of stress. Right? So how does it help? Well, all the stress, you have oxygen deprivation and so forth. These catecholamines help you deal with oxygen deprivation and prepares the child to breathe. Now, typical child is about 20 inches, 7.5 pounds. Boys tend to be heavier than girls. Head tends to be larger than the body, tends to look like a cone head from the old Saturday Night Live. Upon delivery, we test the child. We want to see if the child is viable or whether it needs a medical intervention right away. And what we do is we test it using the Apgar Scale. That's 5 points of measure, as you'll see on the slide: heart rate, respiration, reflexes, muscle tone, and color. And you could have non-existent, poor, or very strong. We test the child 1 minute and 5 minutes after birth, and the rationale is some children take a little longer to adjust, and we're cognizant of that. So any score of 7 or above is fine. Both of my children were 9s. Anything between 4 to 6 requires attention. Anything 3 or below, the child's in serious danger. So how do we deliver? Well, there are different kinds of labor and delivery techniques. So natural birth is usually through Lamaze, breathing techniques, coaching of the companion, and it's a vaginal birth, right? And the goal is to try and reduce as much intervention as possible. Now, natural birth, as I said, also implies vaginal birth. Sometimes you cannot have a vaginal birth. We'll talk about that in a minute. The other thing that when we're saying typically a natural birth occurs in a hospital, at least in Western countries, some people don't want to have their child in a hospital. And the reason is that it's chaotic. It's chaos. A lot of loud noises and whatnot. So they choose to have a home birth. And I want to be clear that a home birth is perfectly fine as long as you have a doctor or a midwife or nurse practitioner or whatever on staff ready to intervene as necessary. Home births are fine. Now, I said sometimes you might have a C-section. Why would you have a C-section? Well, the child could have turned and the head is not faced downward towards the vagina, so you might not be able to deliver naturally. So you might do a C-section to take out the child so that there's no damage. Another time you might want to do a C-section is when there's STDs or STIs. For example, if a person has herpes, you would not want to do a vaginal birth. You might do a C-section for that purpose. Any emergency procedure is likely to be C-section. And some people actually prefer C-section or cesarean section because they can plan when they're going to deliver. So, how do we help? What are some of the medication we give? There's analgesic, anesthetics, and oxytocics. Analgesics, such as an epidural, are painkillers. The contractions are painful. You inject it into the lower spine, and then it numbs the lower extremities. Anesthetics is more topical, and instead of being a painkiller where the pain is there but it reduces it, anesthetics block sensation altogether. So these are your two ways to deal with pain. And then we have oxytocics. This is to stimulate contractions. Let's say a person has not progressed and dilated in a face. You might use Pitocin, which is the common brand name. So you're delivering. There can be potential problems such as anoxia. Anoxia is where the child's not getting enough oxygen. How does that happen? Many ways. One is the child is breech, and as I said, it turns and it pinches the umbilical cord, which, as we said, was very responsible for oxygen and blood flow. So that could be an emergency issue where there's not enough oxygen. We also have placenta abruptio, which is where the placenta separates, and the placenta is on the other side of the umbilical cord, and that could be exceedingly problematic in terms of oxygen. And then we have RH factor incompatibility, and this is a fascinating one where the fetus and the mom's blood are viewed as antagonistic, and the mom is viewed as a foreign entity, and the antibodies start to attack the fetus's red blood cells and vice versa, and that could result in oxygen deprivation. Okay, so we talked about labor and delivery. Mazel tov, congratulations, you have your baby. As I said, normal gestation is 38 to 42 weeks. A preemie is anything before 38 weeks, and a micropreemie is 27 weeks or less. Normal weight is 5.5 pounds. You'll notice that 5.5 pounds is lower than the typical weight of 7 pounds, but low birth weight is anything under 3 pounds. Now, there is something called a kilo kid, kilo being kilogram, 2.2 pounds or less, and that usually occurs with substance abusers. And you're probably saying, hey, wait, kilo, are you talking about a kilo of drugs? No, it's that due to drug abuse, the child is usually born very early and underweight, 2.2 pounds or less. So that's another reason not to use drugs and alcohol during a pregnancy. And then there's something called, we have your weight, we have your gestational age, but we have a trajectory based on a certain number of weeks how much the weight should be. So there's something called small for gestational age, and that says, well, if you're this many weeks, you should weigh this much. And there are some fetuses that are even lower than the expected weight at that time, and this is the worst of all. So what happens when you have a preemie or a micropreemie or a child with low birth weight many times? Well, they wind up in a neonatal intensive care unit. So they wind up being put in the plexiglass chambers, which we call an isolette, that regulates temperature, airflow, breathing, food, medication. They really look like they're in terrible shape. A lot of tubes going everywhere. very unresponsive, scrawny, etc. And what we see is they're typically held less than full-term babies, and that's a problem. So now, if we look like held versus handled, that's different. So if we look at, there was a study by Lawson and colleagues in the NICU. What does it look like for these kids? So these kids are handled the same, but it's not the cuddling, it's not the stroking, it's their flip, change, let's do this, let's do that. It's a lot of moving the body in a non-loving way. Cycle of day, we see these kids, day is day, night is night. The cycle of day is the same. Now, the sound, remember I said some people want to deliver at home? Because the sound is almost as if you're on a street corner or on a bus, very loud with all the noises in a hospital. So it's not as soothing. And then sight, one of the things we see